Of Executive Committee, on behalf of the Executive Committee and Board of Directors of Indian Academy of Cerebral Palsy, I extend a very warm welcome to all of you to the National Cerebral Palsy Day celebrations and today's webinar on evaluation and management of upper limb cerebral palsy. National Cerebral Palsy Day is observed to express our gratitude to late Dr. Perin K. Mullah Feroz, a former medical director and orthopedic surgeon at the Children's Orthopedic Hospital in Mumbai, a true pioneer who dedicated her life to the care of children with disabilities and laid the foundation for interdisciplinary management of CP in India. It's my pleasure to warmly welcome our distinguished speaker, Dr. Easwar Ramani, sir, a senior consultant in pediatric orthopedics. Thank you, sir, for accepting our invitation and sharing your expertise with us. A warm welcome as well to Dr. Sakti Das, sir, a senior consultant in pediatric orthopedics and IICP secretary, for kindly agreeing to moderate today's session. We also take pleasure in welcoming our special invitees and achievers, Mr. Ali Muzaffar and Mr. Vivek Joshi.
Thank you for the invitation. It is a privilege to actually talk to such an august audience. And sir mentioned that I've come here to teach. Rather than teach, it is just sharing my experience. And I'm sure among the audience there are so many people who are much more experienced. I'm just humbled with the opportunity given to me. So I basically, this is the premise of my talk. This is a cerebral palsy child who I was treating. He is 14 years of age, and he is a athlete. He competes in national junior events. He has won the bronze in the national junior events. And when I saw him the first time, I had operated on his lower limb, and subsequently he won the award, which itself gave me a lot of pleasure. But when I asked him about his hand, he said that he has gone to so many doctors and nobody has actually even thought about offering anything for the hand. So he thought there was no treatment available for the hand. So cerebral palsy, we all concentrate so much on the child's ability to walk properly and ambulate, that we forget that hand is such an important part of the societal integration, community integration. And it is important that we do spend time to know about hand function. So even for a child who is an achiever like this, the hand gets neglected. So cerebral palsy, just to introduce, it's a static brain lesion. Recently, the definition has been quite overhauled in in a more verbose way. And the upper limb is involved in as many as 83% of children with cerebral palsy. In spite of that, it receives much less attention than the lower limbs. And 69% of children demonstrate some kind of issues with the ability to use the hand. So profound impact on activities of daily living and education and vocation is what results from hand impairment. So the pathoanatomy of the upper limb, we will go through that. We will talk about the functional impairments. Then we will talk a lot about the means to assess the impairment. And that is where the key is, unlike in the lower limbs. Then we'll go through the treatment approaches. We'll first look at the non-surgical treatment approach. Then we'll go into the surgical treatment approach. Generally wrap up with the principles of evaluation of upper limb. So the primary problem is that the central nervous system issue in cerebral palsy is a static one and it is a non-progressive one in the brain. It occurs during the developmental period, either during the immediate perinatal period or the immediate postnatal period. In either way, it is a static lesion. It is non-degenerative, but the spasm, the deformities and all that do tend to progress and become worse with time. It affects mainly the motor control and posture. There are several secondary issues which can happen. The main thing, of course, is spasticity and dystonia. There is also the issue of muscle being actually weak. Many people confuse the fact that the child has dystonia or spasticity, and they confuse and they say that the child is having very strong muscles. It's not strong, actually the muscles are weak. And there is also the impairment in selective control. In quite often, the therapists would be very familiar with this. If you ask the child to move, isolate and move, say, one finger or just one joint, the child cannot do that and tends to flail up the entire limb. So he cannot isolate a movement, and this results in a major impairment, especially of the fine motor activities. Sensory deficits are also there, and pain is also a very, very important factor. And an abnormal muscle tone. Abnormal muscle tone can be either a spasm or it can be any other dystonia, like we will see. So all this combination of factors lead on to muscle contractures. Earlier, we used to think that only the central nervous system is the issue with cerebral palsy. Now it has come to light that there are many problems in the sarcomere structure inside the muscle itself. So it is a lot to do with the muscular structure. The cellular structure also gets disturbed as the child grows. So it's not only a central nervous system issue. Anyway, the secondary problems lead on to the tertiary problems, which are the fixed contractures in the muscles. The issues with the bone tend to get molded by the spastic muscles and lead to bony deformities. And eventually the joint above and joint below, instability. There are growth disturbances. It's quite not uncommon to find children high length discrepancies.
Join
Spasticity starts first. Spasticity starts first and then slowly leads on to the contracture. Spasticity is otherwise called hyperexcitability or hyperreflexia to the stretch reflex. A stretch reflex is the reflex of the muscle when you stretch it. That is what happens when you test for a tendon jerk. When you suddenly stretch the muscle, it jerks back. And that movement is called spasticity. It is a velocity dependent reaction of the muscle to stretch. Now, eventually the contractures develop and then we have limitation of the joint movement. Joint gets contracted and there will be structural changes in the capsule, in the soft tissues, in the bone itself. And this contractures require surgical intervention. As far as the upper limb is concerned, the main muscles from the shoulder onwards, which are responsible for this, are the pectoralis major, the subscapularis, elbow, the biceps and the brachialis, and the pronators of the forearm, the pronator teres and the pronator quadratus. And in the wrist, the flexors are getting tight, the flexor carpi radialis and flexor carpi ulnaris. And in the hand, the thumb muscles, the intrinsic muscles of the thumb and all the intrinsics of the fingers as well. These are the muscles which are chiefly getting spastic and then they eventually go into contractures. So the common deformities follow the same pattern as these muscles get affected. You will have a shoulder adduction contracture because the pectoralis major is there and the shoulder internal rotation contracture because the subscapularis is getting contracted. Elbow, similarly, because the biceps and the brachialis are getting contracted, you will have a flexion contracture. And in the forearm, both your pronators, your pronator teres and pronator quadratus are getting contracted. So you will have a pronation contracture in the forearm. The wrist, the flexor carpi radialis and the flexor carpi ulnaris, along with the finger flexors, but mainly the wrist flexors getting contracted. So the wrist will be in flexion, a spasm to start with, and then go on to contractures. And similarly, the thumb, because the intrinsics are contracted, the thumb results in what is called a thumb in palm deformity, where actually the child will have a clasped thumb. And the different stages of this thumb deformity are categorized as shown in the diagram. So there are several difficulties with the daily living and a limited range of motion and fine motor skills this causes. So the clinical examination of cerebral palsy is a multi-layered approach. Unlike in the lower limb where you tend to see the gait and you tend to examine the child and then move on to the treatment. Here you have to check the active range of motion, the passive range of motion, child's ability to perform skilled tasks in day-to-day life, and then you assess the tone and contractures separately. And everything has then to be stitched together to get an overall clinical picture. And that is where the upper limb assessment differs from the lower limb assessment. And that is where the upper limb assessment is tricky also. So you have muscle strength. That is one of the main things. And then you have to look for the selective motor control. You have to grade the muscle for the motor power. Then you have to check how the child is using and whether the child can isolate a particular muscle to do a fine movement or isolate a single joint to move. Like this child, you can see that quite clearly. She has a pronation contracture. The active supination and passive supination is restricted. And you can also see that she is unable to straighten the elbow fully. Then we have to see her use this hand in daily functions, daily chores, and see how they are interfered. An additional compounding factor in any upper limb assessment is not necessarily spasm, it is dystonia. Look, for example, this child. She actually needs to use her other hand to kind of untwist this hand to put it into the position, and that is causing tremendous frustration to her. She is about 18 years of age, and she has not been treated for her upper limb issues, and she has got severe dystonia. So even though there is no contracture, and when you make her relax, there is absolutely no contracture, and she can bring it up nicely into dorsiflexion, the wrist. This entire arm goes into complete dystonia. And this is something that you have to watch out for because the treatment is very difficult here. In addition to this dystonia, this patient will have what is called dysdiadochokinesis. Dysdiadochokinesis is difficulty in performing alternate movements. Like in music, how you do this, this movement to appreciate music. So this repeated supination and pronation is interfered with. So these children will have dysdiadochokinesis and also astereognosis. And astereognosis is a particular red flag for any surgeries we may plan. Astereognosis results in the child not being able to feel what is inside the hand. And that is a very difficult problem to solve. Added on to this, all your regular different types of cerebral palsy compound the picture even more. So you have on the top here, this boy trying to pick up this bottle, and he has got an athetotic cerebral palsy. And then you have this girl who's just trying to hold on to the handle. I'm just asking her to hold on to the handle of her wheelchair. And you see how dystonic she becomes when she wants to do an intended movement. And this third child is an ataxic cerebral palsy, where he has no control over his own balance. And the whole trunk just sways back. So this has got a lot of positioning issues, and upper limb use becomes particularly difficult. The last one, the child in blue, who's sitting on the floor, is trying to get up now, but you see how immediately on getting up, he'll just flop down. This is a dystonic cerebral palsy, and these variants add and compound our problem in assessing the upper limb for any sort of intervention we may plan. And so it is not at all as straightforward as the lower limbs. This is the particular problem with the upper limb, and this is why it is special. You have bimanual actions. There are several actions we do in our daily life where we need to use both the hands. For example, I'll take this bottle, and if I use this bottle, I need to use two hands. So this is a bimanual operation. And I need to use one hand to open the cap and one hand to stabilize. So this is an asymmetric bimanual operation. Unlike if somebody gives you a bowl of fruits or a child a bowl of fruits and you receive it with two hands, the both hands are doing the same thing. So that then becomes a symmetric action with a common goal. So there is a common goal and asymmetric action. There is a common goal and there is a symmetric action. And some of these actions are cooperative, like opening a box and taking things out of the box. Some of these are parallel actions. So all these impairments result in a complicated picture, which we will have to take into consideration. We need to look for the spasm, in some way assess the spasm, and there are several tools for that. Modified Ashworth, even though with all the shortcomings, is one of the tools where you grade it from 0, 1, 1 plus, 2, 3, and 4. 4 being the most toughest to get the child moving. This is a passive movement you do. You do it in 1 second and see how much can be moved. If it can't be moved at all, that is 4. If it is very, very mild, it is 0 or 1 or 1 plus. But it is very difficult to grade. It changes. There is a lot of variability between the users for this scale. And so it is not an absolute. I may feel that it is 1, somebody else may feel it is 1 plus or 2. So there is a lot of inter-observer variability. Another scale we can use is Manual Ability Classification, or MACS. And this is level 1. Level 1 means you can use all the objects unhindered all the time in regular speed without any change in the object or the surface. Level 2, there is some amount of problem, but he can do it, but it is very slow. 3 means he needs some change or adaptive stuff to happen so that he can use it. And 4, he needs to actually change the object, like children who need to hold on to special pens with a special grip and all that belong in level 4. And 5 is very difficult. He can't use or handle the objects. So this is a very broad MACS classification. It is somewhat similar to our GMFCS, which we do for our lower limbs. And this is the most popular one. It is very, very difficult, but it is very extensive. So it takes up a lot of time. It takes as much as about 30 to 40 minutes of our clinic time. So obviously not practical for clinicians to do it in the outpatients, but our physician assistants and our fellows are trained to do this. And for those of you who are interested, the form which is detailed, which has the detailed set of instructions on how to implement this, is downloadable from this QR code. So this is called SHUI, SHUI in short, for Shriner Hospital Upper Extremity Evaluation. And so this assesses the child in 2 ways. So there are two components for this. One component is what I have put here in the lower part of the question mark is the clinical assessment. Here you look at the joint motion, you look at the activities of daily living, and you look at the tone. So that is the first part of SHUI. Then the second part of SHUI is the video analysis. And the video analysis is very extensive. And the video analysis has got 3 components into it. One is the spontaneous function. So that there are about 16 tasks you have got to do. 9 of these tasks get scored, and they assess the function of the upper limb in spontaneous movements. Then various dynamic positions, and then grasp and release. So this is how it is assessed. I don't want to take up too much of time going into the detail. It is enough that the audience gets acquainted with SHUI if they are not using it in their own clinical practice. For those of you who are doing upper limb therapy and treatment, this is a very important tool to know about because it is kind of expensive. Built into SHUI, which is a rather older publication, is House Functional Classification, which is part of SHUI, but it is of an older publication. And then dynamic position analysis is the second part of the video analysis, where you are assessing the upper limb in segments. We are assessing the individual joints, and then we are totaling up the points. And the third is the ability of grasp and release. Quite often we assess everything, but we don't assess the suitability of the hand to grasp, don't assess it to release. So this is taking care of that. So that way the SHUI is a very all-around classification system. And again, I'm just presenting the QR code. I don't want to delve into too much detail here. So those of you who are interested can take a screenshot and use this QR code to get the form. It's very detailed. So these are about the items which can be used. These items are videotaped. These are all the SHUI items which are used to tape the activity. But we are developing our own scale at the places where I practice, and we are evolving and we are validating the current scale. We have combined the best aspects and we have thinned down some other things to develop our own scales, and we are in the process of validating it now. So this is what I mean by asymmetric action. This is cooperative, and this is an extremely skilled action which this child is able to do very well. And we are using it, things like this in our local adaptation of these things with fine motor work which this child is doing. And things like normal stuff like eating, dressing oneself, all these are included in our local adaptation. So we are trying to make SHUI more practical for use in the outpatient, so that our upper limb evaluation finishes faster and it's still all encompassing. So that is the assessment. So the child comes to you with a difficulty. You have looked at the upper limb. We have assessed whether it is spasm or dystonia. We have made sure that the child doesn't have any astereognosis, dysdiadochokinesis. We have made sure that there is no contractures. We have looked at the motor power and then joint range of motion. And you have done a SHUI classification. Now it is time to go into treatment. The treatment, non-surgical treatment approaches, I start with tone inhibiting cast. These have worked very well in my practice for the upper limb, and many times I'm able to avoid Botox injection into the upper limbs. I need to get to do it under a short general anesthesia, but the hand function improves so much, and the spasm and contractures, mild contractures, can be relieved so very well with tone inhibiting casts. Botox is very good, very useful. I use a short general anesthesia, an ultrasound compulsorily, and inject into the offending muscles, and specifically the pronator, the wrist flexors, biceps, and also the thumb intrinsics, and it works very well. I have used it alone or in combination with the tone inhibiting cast, and I find the tone inhibiting cast and Botox sometimes work synergistically better together. But after the evaluation, as you enter the treatment, regardless of the specialty you practice, you will need help, especially with the upper limb. It is a different ball game when compared to the lower limb cerebral palsy treatment. Your upper limb, your colleagues are your best favors. You need all of your colleagues on your side, and they need to be on the same page when it comes to treatment. The team is absolutely important. You need to consult the neurologist. You need to make sure that there is no dystonic or astereognosis element to the whole thing. And you need to get the therapists in line. The therapist needs to be sure as to what you're going to do, what is the plan of care, what splints they're going to offer, and what is the therapy that they are going to plan for a particular child. And that is why it is very important to share your SHUI scores with your therapist, and the therapist be aware of the SHUI score so that we can communicate in a scientific language. The tone inhibiting cast, like I said, it gives you a very gentle stretch, and also the tone goes down with it. Mild contractures can be relieved. It is not the aim to stretch it out. It is more of a total contact type of cast, but it does offer significant relief in spasm. In my hands, at least, the effect of a tone inhibiting cast on the upper limb exceeds at least 6 months, quite comparable with that of Botox. Botox is of course very well used, like in the lower limb, it is used in the upper limb also. It needs a short general anesthetic. There is a dose restriction that we have to, and it is you have to give it into the offending muscles, which is we have evaluated before. Then you plan physiotherapy. The physiotherapy is a little different for the upper limb. The therapy focuses on range of motion, strengthening, functional movements, and of course, for the lower limb, gait training. Along with that, we have to focus on the upper limb, and upper limb focus on physiotherapy is mostly strength-based. But for occupational therapy, we need to cultivate those very movements of hand that are very important for day-to-day life and functions. And that is much, much more profound and telling effects on the child. Simple things like adaptive equipment, sensory integration. Spite of these children, a lot of these children have sensory issues with their hands. So they need to touch and feel an object and understand the texture, and then slowly start using that. Splints are can work wonders, like this child here. On first glance, child using a wheelchair like this, you feel that you need to go in and do surgery. This child is a GMFCS 5, and we can see that this child improves significantly with the use of just orthosis. You can see that he's using the joystick much better with the orthosis. This is a upper limb above elbow orthosis for the pronation, and see how this child again improves with the use of orthosis. So orthosis, hand splints, particularly dynamic splints, can work wonders. It can relieve the spasm, even when the spasm looks so bad and the contraction looks so bad. Most of it, if it is dynamic, it just needs a functional splint, and a child can do basic functions using that splint. So it is important to understand the contractures and the spasm and the dystonia as separate entities, and then decide on the splint. So there are several splints. The occupational therapist, your hand splinting expert in your institutions, you'll have to work with them, and then they need your inputs, and then they will design your splints for use. I am fortunate that there is a upper limb splint fabrication in the institute where I work, in the National Institute. Thanks for Surya Prakash, who is the occupational therapist and hand splinting person in charge of this. So he designs our splints, and this hand splinting equipment can be made fully in-house with minimal expense. And all it needs is a therapy team who's happy and to work together to pull it off. And this ensures that your hand splinting unit is up and running, and you can coordinate with them, you can get feedback to them, and keep modifying the splint as the child's therapy improves. Once this splinting or non-operative treatment is done with, then you move into the surgical zone. The surgical zone in upper limb surgeries are mainly for fixed contractures, for functional limitations where you may need to do tendon transfers. And then at post-skeletal maturity, there may be bony changes which you may need to address. And these bony deformities and fixed contractures will need bony surgeries. So most of these upper limb procedures in our country, because the upper limb is neglected, they come to us in early adolescence or late adolescence. A few that we are treated have come in late childhood. It is, as I said, a multidisciplinary decision. We'll have to comprehensively evaluate pre-op and tackle all the problems right from shoulder down to the thumb in one go, or as much as possible in one go. So it's like a single event, multi-level procedure. So there are several surgeries which are done. This is child, we test the pronation contracture in the operation theater. And this is the surgery we are planning the release. So that's planned for a biceps lengthening and a brachialis lengthening, a capsular release, and the incision below is for a pronator teres, and this is a pronator quadratus release. So all these releases are done simultaneously, and these releases are fractional lengthenings. Only the aponeurotic part is lengthened, carefully protecting the neurovascular bundles. So we'll be encountering the ulnar nerve there, the median nerve there, and that is the biceps aponeurosis, which will lengthen. I can see that the biceps tendon there, that will be lengthened. So once the stage of soft tissue surgeries are done, then you move on to tendon transfers and arthrodesis. Arthrodesis is fusing a joint which is not moving particularly well. So for the shoulder, the offending structures, as we discussed earlier, is internal rotation adduction contracture. So those muscles like pectoralis major, subscapularis can be lengthened. And latissimus dorsi and teres major can be transferred to improve the abduction in many of these children. Elbows, we have to lengthen the biceps and brachialis. If you have an elbow flexion contractures, you can advance the triceps to improve the extension power and to address the flexion contractures. Forearm, you have an option to lengthen or reroute the pronator teres so that it becomes a supinator of the forearm. And flexor pronator slide is another surgery that we can do. So this is a child where we have done the flexor release with this incision, and now we are doing the pronator release with this incision. That is the radial artery, which is very close by. So we can do a pronator lengthening. Once the pronator teres is lengthened, and there is option to reroute this as well down the. We have done that. We move on to the where we have isolated the transverse head of adductor pollicis, and the adductor pollicis can then be sectioned. And you can see that just under this isolated adductor pollicis is the transverse palmar arch. So under this is the transverse palmar arch. That is the of the radial arch. So once these surgeries are done, now you can see that this paw is able to grip the bottle nicely with an abducted thumb. The thumb can abduct out of the palm and is able to circle around the bottle, and he is able to use both hands. A bimanual use and a cooperative way is possible. The fine motor activity has improved. There is a tip to side pinch, not a tip to tip pinch, but it was much worse to start with. And he is able to just start holding the pen, and there is a long rehab road ahead of it. As far as the wrist and hand are concerned, and if there is a deficiency, quite often we see that there is a ulnar deviation of the wrist and flexion of the wrist. So these children will be using this hand in an ulnar deviation and a flexion. And this is called the minus position of the wrist, and it is very difficult to use the wrist in a flexed and ulnar deviated way. And so there are several solutions available for this. One is a tendon transfer of flexor carpi ulnaris, and then if in severe contractures, we may need to do a wrist arthrodesis. So this is a the same child. We have done the flexor tendon slide. We have done the pronator teres lengthening. And now we have done the adductor lengthening with an Z-plasty for the thumb space, web space contractures. So that many children have this thumb in palm. So we have abducted the thumb nicely out of the palm. Once that is done, this child has a flexed wrist, which is not able to actively extend. So we are harvesting the flexor carpi ulnaris from here. That's a harvested flexor carpi ulnaris. You can actually see the ulnar vessels here. So flexor carpi ulnaris tendon is harvested. It is rerouted to the extensor side. And on the extensor side, we attach it to either the extensor digitorum communis or extensor carpi radialis longus. And once we have done that, we can see that the wrist is in nice dorsiflexion here. And so it has moved out. So the tendon transfer is staying, and we can see how nicely the thumb is also abducted out. So once that is done, the child is done the rehab, and you can see how beautifully the child's thumb is nicely abducting out of the palm, and he's able to do the opposition movement of the thumb, and he's able to take an imaginary food to the mouth, and you can see that he's also able to hold on to the bottle. The interphalangeal joint of the thumb is still in extension. If you see how he's trying to grab the bottle, the interphalangeal joint of the thumb is still in extension, and this is something that it needs to be addressed going forward, and it can be addressed to improve the interphalangeal flexion. You can reroute the extensor pollicis longus into the flexor side so that we can flex the distal interphalangeal joint of the thumb. So that one procedure that we have kept as for the future if he doesn't rehab very well. So the single event multi-level surgeries has the advantage of a single anesthesia and a single rehabilitation period. But it also, you need to bring in your rehab colleagues. It has a longer surgery and a much more complicated rehab procedure. And all the parts of the team has to work together, and they all will have to be carefully choreographed and planned. So multi-level assessment is very important. Specific problems of each joint has to be considered. Impairment in function and the function itself has to be checked as two separate entities. You have to not stop with just the superficial clinical examination. Make it scientific and use standardized assessment tools to seal whatever you have found out in the clinical examination and codify it so that you can share with your colleagues, because it doesn't end with a Botox or a plaster or a surgery. It has to extend into the therapy session. And realistic goals are very important. It is not a normal hand. We are trying to solve some of the functional issues the child is having. Upper limb dysfunctions can significantly impact life. It is very important to know that in conclusion. Comprehensive assessment is important. And whether you are a therapist, you will need the surgeon. If I am a surgeon, I will need the therapist. We will need the neurologist to be on board. We will need the pediatricians to be on board. This is a team game. It is much different from a lower limb cerebral palsy that we routinely concentrate on. Upper limb requires the whole team to be on board so that you can work with the team much more than the lower limb. The whole cerebral palsy is a team game, but much more so for the upper limb. But if you properly rehabbed and properly planned, this is a 16-year-old boy who came to us much neglected with the upper limb, with hardly any function of the upper limb. So we did single even multi-level surgeries, and with carefully planned surgeries and an excellent physio team who have worked tirelessly, and his mother, I should especially congratulate that she's worked several years actually behind him to get him to a functional level where he can use the left hand in active way to do asymmetric movements, cooperative movements, and you can see how beautifully he is holding on to the glass and pouring without spilling, and eating with his fingers. So this is the result. This is the reward for careful assessment and teamwork. These are my references. And thank you very much for the opportunity. I think it is a privilege to be talking to the members of ASC. Thank you very much. Thank you, sir.
Thank you, doctors, for wonderful presentation. And today I'm very happy that Dr. Purohit sir joined and Dr. Dhiren Ganjwala also joined this session. I think Dr. Purohit joined from USA and Dr. Dhiren sir is in Europe on tour. And I request them to give their just overview on this talk.
To be actually honest with you, it's great to see actually Purohit sir here. One of my very early on in my career, I saw a patient who was operated by Purohit sir on upper limb, and he has done median nerve
Fasciculotomy.
and the results were so good even after so many years. That was one of the early inspirations which I had. Yes.
Dr. Purohit sir.
Yes. Good evening, good morning, wherever in the world, whatever the timings. My best wishes to all the audience and especially Dr. Easwar. He has really, like Easwar, godly, he has presented the truth, what is he doing it. Congratulations. Now the 2-3 things as Dr. Gangjwal has already mentioned about the selective motor fasciculotomy, that is selective neurotomy also. Dr. Easwar has nicely mentioned the name, but Dr. Easwar did not say anything about it. What we feel is that neuro-orthoplastic approach is the best approach for the upper limb when a surgical part comes. However, before that, as mentioned, the occupational therapist and many other things do come into picture. And when the resistance develop to those all kinds of the non-surgical, non-invasive measures, then we, the surgeons, neuro-orthoplastic come into picture. Now, the thing is that the challenges are, as far as botulinum toxin is concerned, after 1 or 2 injections, which we should give in a very young age only, the resistance develops. Then the question comes that can we also again have a neuro approach to take care of this spasticity or dystonia? Yes. Then comes the selective motor fasciculotomy, plus minus the muscular surgeries. Especially in the dystonia, I have found that it is very, very bad to release the muscles of the dystonic muscles by any kind of a orthopedic procedures. There we have found that good results can be given to them when we perform selective motor fasciculotomy. So I think in this armamentarium of the management, which Dr. Easwar has mentioned, extremely good, we have to think about the relief of spasticity and dystonia also along with these things by selective motor fasciculotomy. And before that, yes, in very young people, one may try about the botulinum toxin. Okay, another one important thing which I would like to mention that we actually believe in multi-stage, single or multi-level surgeries. Because as the child is growing, we find that at particular stage, some kind of the hyperkinetic or spasticity or dystonia come into picture. We only believe that trim only that one which is coming in the way, not to go at a time for a multiple levels of the orthopedic surgeries. Instead of that, we may take them into confidence, the family, and then only trim that which comes, which is harmful. And in between the 2 procedures, take again care of the non-invasive measures, occupational therapy, physiotherapy, orthotics, etc., etc. So that one message, neuro-orthoplastic approach. Second is multi-stage, multi or single level neuro-ortho procedures. In between, again taking care with the help of the physiotherapist or occupational therapist. Over to you all with again congratulations. Thank you.
Thank you, sir. And may I request Dr. Dhiren sir to speak? his comments.
Yeah, Ishwar is really well given the perspective of the orthopedic surgeon, but Dr. Purohit mentioned that when it comes to upper extremity management, we need to take off a procedure like selective motor fasciculectomy, because when there is a contracture, yes, we need to relieve by surgery. When there is an imbalance, we need to go for tendon transfer. But when there is mainly a spasticity, in that case, reducing the tone of the muscle by neuro procedure or the fasciculectomy would definitely work. But we have to be very selective and should not end up with too much of weakness. But once again, congratulations, Ishwar, for wonderful covering. I would always consider this as a 360-degree overview of the topic. Congratulations once again. Thank you.
Thank you, sir. Now Lakshit will present questions to Shaktidas sir so that he can speak, answer.
So let me again thank you, Easwar, for the extensive discussion on the assessment management, all the therapeutic management, orthotics managements, and also surgical part. Though in a very less number of cases, we indication of surgery are there because many children are with some of the dystonia, some other problems are there. Very specific cases and need surgery. Anyhow, but there are a lot of questions for you. From the my first question goes to Dr. Preeti. Preeti asked, considering stability, considering Easwar.
Sir, there is a question, what about deformity in lower limb?
Sir, can I ask the questions to?
Yeah. Asha, please.
Yeah,
Yes,
the
you
first
can.
question to you, sir, is how does one decide to target which muscles should be given Botox to improve overall function, considering stability and mobility?
Considering stability and mobility, madam, can you elaborate on stability or stability of upper limb?
Preeti, what is your question? What were you trying to ask you? Is it stability and mobility? So are you asking proximal stability and mobility distally? What do you want to ask, sir? It's question from Miss Dr. Preeti.
I think she left.
Anyhow, Easwar, you can ask how you see, how you decide to give the buttocks. How you decide to give the buttocks to which muscle or any specific muscle.
So that is why I went through the initial phase of clinical assessment, and I call it a multi-layered clinical assessment, where you test for the passive range of motion, thereby isolating the contractures, active range of motion, thereby looking for selective motor action ability, plus also looking at the spasm. The predominant spasm can then be understood by the active movements. And in addition to that, we are also checking for the spasm and power. So these four things help us identify which muscle is the one which needs to be targeted. And in cerebral palsy, there is a standard pattern in which these muscles are spastic. For each joint, there are usually 2 or 3 muscles which are the usual culprits. So we tend to zero in on those, and that is based on the position of the spasm the hand is in. So the Botox is fairly standard, by the position of the hand in spasm, we'll be able to decide.
Thank you, sir. The second question to you is, sir, do you use CIMT and Habit ILE? The test.
No, ma'am, I'm not familiar with those two tests. CIMT, that's for, is it an assessment scale? I am not.
Correct, sir. It is. CIMT is a treatment and Habit is an assessment scale. Yes, sir.
No,
Used
ma'am.
by OTs.
Okay. I'm not familiar with that. I mean, maybe the OTs, they'll be more in the audience. They may be more.
Yeah. You're very right, sir. Habit is a assessment outcome measure where OTs are trained and it's a certification and people who are trained can use it. Thank
Okay.
you, sir. Sir, the other question to you is how exoskeleton helps a child with cerebral palsy and its uses. Can every child use it, and is there any side effects of Botox?
Side effect of Botox, I'll answer first. I did not want to elaborate too much, but there are recent papers which show that there is some atrophy of the muscles which does happen with Botox. But the thing is that we need some tool to allow the spasm to be overcome. And in that sense, Botox is one of the tools. I have used alcohol injection in the hand. I have used nerve stimulator, and using the nerve stimulator, I have injected absolute alcohol, 40% absolute alcohol, and that works very well. And it produces a reversible, controlled lessening of the spasm, and it restores the power back. So that is there, but definitely it also may cause some injury to the tissue. So regardless of what you inject, whether it be phenol, whether it be alcohol, whether it be Botox, it does injure the tissues. But we do need some intervention. Remember, when you do give Botox, you're already at a stage where the spasm, something needs to be done to improve the child. So this is a small price we pay for that. That is as far as Botox. Your second question, ma'am, you wanted exoskeleton. So
Yeah.
the exoskeleton, I have not personally experienced. One of my cerebral palsy patients, the lower limb surgeries whom I have done, is starting to use exoskeleton for the past few months now. And he's noting some improvement in his ability, but it is useful only if the cognition level of the child is good enough. Otherwise, it will be just, the child is made to sit in it, and it goes through the motions. It may not be that useful. But my experience with exoskeleton is limited.
Thank you, sir. And I think, second, if I'm allowed to add, exoskeletons, you need to identify a child well, as sir said about cognitive abilities, but also it needs to have some kind of postural control. If you don't have that kind of postural control, and if you just put somebody in a locomat, that doesn't mean what he does there would enhance walking. So there's a huge hype on that, but I think so we need to really not forget that hands-on therapy still remains and adjuncts can make a little difference. Thank you, sir. So the other question to you is the part of the question you answered about how do you pick up abnormal movements in the muscles, but there's an added question to that. It says that when you do assessment, do you pay attention to the shoulder and trunk as well, especially when CP is a whole body problem?
Yeah, of course. The upper limb, I was just restricting myself from the upper limb, but technically upper limb starts from the scapula. So we have to start from the scapula, at least the shoulder. So we have to pay attention to the trunk, because the trunk position and the way you move your girdle affects the way it cascades down to the hand. Certainly.
Thank you, sir. Sir, another question is, torsional bony correction can be done to correct pronation. At what age maximum or at the earliest age to be intervened, or just release of pronators is enough? That's the first question.
So the child which I showed you last, the child who had excellent function, that child came to me almost near skeletal maturity, and he had fixed pronation contracture, and I thought I would need a bony deformity. But in fact, I didn't do a single stage multi-level release for him. I staged the release because I wanted to understand whether a bony correction would be required or a soft tissue will work for him. So like what Purohit has said, I staged the surgical release, and I did 3-stage release for him. And I found that with each release, and then a plaster, and then a therapy period, and then coming back for the second surgery, we could get him through without a bony surgery with a fair degree of function. But I have done pronation contracture osteotomy for a child, near skeletal maturity, who had, fixed this image. Actually, I posted in this talk first. It's a completely contracted hand where I had to do a pronation contracture with a osteotomy. So that is required if it is too tight. But in some of these cases, we can do with multi-stage surgery and plaster and therapy sessions in between. We can kind of avoid it if it is not so pronounced.
Thank you, sir. There are one or two more questions. Mallikarjun sir will send those to you, but more or less you've covered everything.